A silicone-filled eye with posterior polar cataract is posted for a cataract surgery. A trocar is inserted beforehand at pars plana, 2.8 millimeter keratome entry through the anterior sclera and adjacent cornea. Viscoelastic fills the eye, antechamber. Tunnel floor entry technique with a cystotome which is bent at 45 degrees completes the rhexis effortlessly. The tunnel is enlarged with a blunt keratome. The anterior opening of the tunnel is further enlarged with 2.8 millimeter keratome, ensuring that the cuts are not directed backwards. Both the internal and external openings are straight. Hydrodissection is performed in spite of there being a posterior polar cataract. Segmental hydrodissection is done. You can see the posterior capsule getting separated from the posterior subcapsular plaque. There is a resistance for rotation, mostly due to the hypotony. AC is filled with viscoelastic. Further hydrodissection is done in one segment, which was not completed earlier. You can see the posterior capsule going back from the opacity further. Now it's easy to rotate the nucleus. It's lifted up by manually into the anterior chamber. It's a hard nucleus. It's bisected into two halves and under the protection of viscoelastic. HPMC is continuously being injected in front of the nucleus. It's a nucleus epinucleus mass. There is no hydrodelineation, only hydrodissection is done, separating the capsule from the peripheral cortex. This enables easy removal of the cortex at the end of surgery without putting any traction to the zonules or to the posterior capsule. You can see the bare area in the center, which connotes the area where the subcapsular capacity was there. There is no rent in the posterior capsule, as it was suspected before surgery on slit lamp examination. You can see the shimmering silicone oil inside the eye. There is no leak of silicone oil into the anterior chamber through porous zonules. IOL is inserted and ensured that it is placed inside the capsular bag. A good rhexis, complete removal of the cortex, and placement of the IOL in the bag is essential. Pupil remains in the center. You can see the viscoelastic is being completely evacuated, both from behind the lens and from the angle region. Thank you.